Welcome to the presentation on the shoulder. My objectives for this presentation are to provide you a brief overview of shoulder anatomy, talk about shoulder injuries, how to prevent them, how they happen, what's their common signs and symptoms, and how do we take care of an individual that has a shoulder injury. Just so you know, the shoulder has a lot of mobility, but has really bad support and stability. The shoulder can be thought of like the hip. The hip has a lot of mobility, like the shoulder, but it has lots more support and stability than our shoulder does. It's often quite a bit. I'm not going to go over every single shoulder injury that can happen in athletics. I'm hitting the highlights. So let's start our discussion talking about the anatomy. We'll start with the bones like we typically do. So we have the clavicle, which is your collar bone. It's an S-shaped bone. Then we have on the posterior or on the back side of our body the scapula, or the wing bone, or the chicken wing bone. Then we have the humerus, which is our upper arm bone. We can think of this like the femur in our lower leg, or our upper leg, sorry. So those are our main bones. Now we're going to talk about joints. Our shoulder joint is called the glenohumeral joint. It is where the head of the humerus contacts the glenoid cavity of the scapula. If we compared the hip to the shoulder joint, you would see that the ball of the femur goes into a bigger cavity in the acetabulum of the hip, whereas the glenoid cavity of the scapula is very narrow, so the ball of the humerus does not sit deeply into the joint, or sorry, the cavity of the scapula. So it has great range of motion, but it doesn't have a lot of stability inside the joint itself. Around the glenoid cavity is a cartilage rim called the glenoid labrum. The reason why I bring that up is I'm not going to talk about labrum tears that much in this class or this presentation, but you may hear about somebody tearing their labrum in their shoulder. That typically happens when we dislocate our shoulder, which we'll talk about a little bit later. So here's our different range of motions within our shoulder, our glenohumeral joint. We have shoulder flexion, shoulder extension, shoulder abduction, which means we're taking it away from our body. Shoulder adduction, bringing the arm back towards our body. Internal and external rotation, as you can see, the arm bent 90 degrees and we rotate it inwards and outwards. Inward is internal, outwards is external rotation. And circumduction is the combination of all those motions. That's making a circle with your arm. So a lot of range of motion here in our shoulder, just like in our hip. Allows us to have to do a lot of actions at our shoulder. Okay, then our next joint is the acromioclavicular joint, the AC joint, and this is where the lateral end of the clavicle articulates with the acromion process of the scapula, as you can see in the picture. There's no range of motion here. Has some ligaments, as you can see in the picture. Not necessary for us in this class to know the names of those ligaments. Now in this picture, this shows a really good picture of the glenohumeral joint. And as you can see here, the head of the humerus just kind of articulates or touches the glenoid cavity there. There's a lot of range of motion, but it can move around in that joint a lot. That's a really good picture to talk about the lack of stability there in the shoulder. Our next joint is called a sternoclavicular joint, or the SC joint. And this is where the medial end, or the inside end of the clavicle, articulates with our sternum, which is the chest bone. Here we have all sorts of range of motions with our SC joint. We have elevation, bringing your shoulders up, depression when your shoulders go down. Protraction is when you bring your arms up, your scapula start. Oh, sorry. Protraction is when you bring your retraction is when you bring your shoulder blades together, and protraction is when you bring those shoulder blades back to normal in the anatomical position. So those are the main joint range of motions there at the SC joint: elevation, depression, protraction, and retraction. And our last joint is the scapulothoracic joint, or ST joint. This is where the scapula articulates with the posterior thoracic cavity, or the back of our ribs. It's really no range of motion, but the scapula has to move with anytime we move our arms. The scapula moves all over the place, but they don't really have a defined range of motion. So some of these you would think that would take place there at the scapulothoracic joint. In some ways they do. So in some textbooks you'll see that they would say that those range of motions take place at the scapulothoracic joint, and some will say they cap in at the SC joint. So just so you're aware of that. For in our class, there is no range of motion. So if a test question comes up, I'll always follow what I have in my lectures. All right. Just so you know, the AC, the SC, and the ST joints are collectively known as the shoulder girdle, and the glenohumeral joint is the shoulder joint. So when I'm talking about the shoulder joint, and when other people are talking about the shoulder joint, they're talking about the glenohumeral joint, just so you're aware of that. Our next area of anatomy is the rotator cuff. There's a ton of muscles in the shoulder. I'm not going to go over all of them in a lab. I'll have a handout with the various muscles around our shoulder. But for the sake of this lecture and for the class, I'm just going to talk about the rotator cuff. So we have 4 muscles in our rotator cuff. We have the supraspinatus, infraspinatus, teres minor, and subscapularis. And you can see that these muscles are attached to, hang out on the scapula. Now, I have here that the range of motion for the rotator cuff is deceleration or slowing down of the arm, but also above I have the supraspinatus responsible for shoulder adduction. Infraspinatus does, and the teres minor does external rotation, and the subscapularis does internal rotation. So which is it? Which range of motion is it? It's both. So when somebody is throwing the ball, say a pitcher or you just throwing the ball, when you release the ball and your arm continues down, that motion of continuing that arm down is adduction, internal and external rotation. But the rotator cuff is responsible for slowing your arm down, and that's when it gets injured, is on that motion, is when the muscles are elongating. So just be aware of that happening. Here's just another picture of the rotator cuff muscles and how they fit with the bigger muscles in our shoulder. How do we prevent shoulder injuries? First is strengthening the shoulder muscles, especially the rotator cuff muscles. Now, the rotator cuff muscles, as you can tell in those pictures, are really small. And so in order for us to actually strengthen the rotator cuff muscles, we have to use smaller weights, or the rubber bands or TheraBands, all those type of things, Because if we get above 5 to 10 pounds, the larger muscles in our shoulders, like the deltoids and the latissimus dorsi, or all those, the lats and all those type of muscles, tend to take over. So in order to isolate those rotator cuff muscles, we have to use smaller weights and build up the endurance on those rotator cuff muscles. You're more interested in that, Google, go on YouTube. You can find tons of exercises to strengthen rotator cuff muscles. Some of you probably have done some of those exercises. Other thing, like every other body part, is warm up, proper warm up and cool down. Teach how to fall correctly. Our natural inclination is to fall in an outstretched arm. That's the incorrect way to fall, because that's, we'll see in all our upper body injuries, that's how most of the upper body injuries happen, is you fall in an outstretched arm. The correct way to fall is the shoulder roll. The volleyball athletes have this down the best. Is you got to bring your arm in and roll on your shoulder. You have to teach yourself how to do this. Now, I don't know how to do this. I haven't been taught how to do it because I was never a volleyball athlete, and I'm a clumsy person. So again, the natural reaction is to use our arm to keep us from falling. But in athletics, we need to teach our athletes how to do the shoulder roll. Other thing is correct throwing, hitting, swimming, etc. mechanics. If somebody's doing the mechanics incorrectly, that's going to eventually show up with an injury, especially with sports that do repeated motions, pitching, hitting, swimming, those type of things. It eventually will catch up to somebody. Appropriate stretching, the rotator cuff stretches, all the upper body stretching. All right, so now we're going to turn our attention to shoulder injuries. Again, I'm not covering every injury in the shoulder. These are just a highlight injuries. So our first injury is a clavicular fracture. That's what FX stands for, is fracture. And our common way that this happens is a fall in an outstretched arm, fall on the tip of your shoulder, or a direct blow to the AC joint. Most of the time, this takes place at the middle 1/3 of the clavicle, as shown in a picture. So our typical signs and symptoms for this injury is athlete will support the arm on the fractured side, and that means that they hold their arm while they're walking because it hurts anytime they move their arm. The head and chin will tilt towards the injured side. The injured clavicle appears lower than the injured side, as you can see in this picture, there's a dip on the shoulder because the clavicle is fractured and has gone down. My friend who had this particular injury, this is exactly what her shoulder looked like. Pain, swelling, point tenderness, like everything. The deformity, just like we're seeing there. Their treatment here is treat for shock, which we talked about earlier in class. Anytime somebody sustains any kind of injury, they're freaked out. You got to get them to calm down. Make sure that the shock doesn't cause worse things than just the regular injury. Immobilize with a sling. Ice it. And we typically need to get this person to the emergency room to get x-rays, probably pain pills, and they're going to have surgery to repair this. Hopefully you go to an orthopedist that repairs this correctly. Our next injury is an AC sprain. Very common in athletics. Similar to a clavicle fracture, but we fall on the AC joint or the tip of the shoulder, or fall with that outstretched arm again. So this picture, what I have it here for is to show the way the force, that's what the black arrow is. It's where that force is going. So the force on the chromium is down, like when you fall on it or get hit on it, and it pushes it down and it tears the ligaments on the AC joint, whereas the one on the middle right shows a force going forward on the clavicle, the lateral clavicle, causing the clavicle to move posteriorly and tearing the ligaments there. So that's what I'm just trying to, the reason why I have that picture there. So the signs and symptoms get worse as the severity increases as you tear more ligaments, because you can see in the picture you have several ligaments around there that I count 4 in the picture. That as you tear more ligaments, the signs and symptoms get worse, which just makes sense. You have tender during movement, especially touching the opposite shoulder. So if you touch your opposite shoulder of the side you're injuring, that really hurts. The lateral clavicle pops up. This is, we can have what's called a positive piano key test, where we push down on the clavicle and it'll go down and come back up like a piano key. Here we need to sling and get to the doctor to rule out a fracture, because they could fracture their clavicle at the same time as they do an AC sprain. Glenohumeral anterior subluxation or dislocation. So let's review what the difference between a subluxation or a dislocation is. And a subluxation is when the body part, the bone pops out and goes back in. A dislocation is when the bone pops out and stays out. So that's the difference between a subluxation and a dislocation. Now, anterior dislocation subluxation accounts for about 50% of all shoulder dislocations. So that's pretty high. And it's anterior because we can do a posterior dislocation too. But this is when the head of the humerus pops out forward or anteriorly. So the MOI, as this is said there, forceful shoulder abduction with external rotation, and that's what that picture shows. Somebody, if you're playing in, I'm going to use football as an example. A defensive player is trying to tackle a running back, but they get past them. They try to grab them with, I'm going to use my right arm. They try to grab them with their right arm. Their arm is abducted, so let's say that the arm is at 90 degrees, and you grab them with your hand. That externally rotates your shoulder as they're running by, and that pops the head of the humerus out in a forward or an anterior direction. So that's what's going on too with this picture. So our signs and symptoms. Athlete will tell you that his or her shoulder popped out of place. This can become a chronic problem too, where the shoulder is constantly popping in and out. Sometimes these are called micro dislocations, where the humerus head is moving all over the place in the shoulder, and this is where that labrum can tear. The deltoid or the shoulder looks flat, like in that picture. Obviously, this guy's got deformity. This person's got chronic glenohumeral subluxations going on, where the guy can just pull his shoulder out of place. Athlete carries his injured arm, and they are unable to touch the opposite shoulder with the injured arm, just like an AC joint. Okay, what's our treatment here? Basically the same as an AC joint. We want to put them in a sling. Need to make sure they don't have a fracture. If this is the first dislocation, we treat it differently than if it's a chronic dislocation. So if it's the first dislocation that happened, never had a dislocation before, we want to get them to the emergency room, or if you have a relationship with your doctor, get them to the doctor's office that quick. But they're going to need to have x-rays to make sure they don't have a fracture somewhere. For some people who have, like in that picture, the athlete's shoulder may just go right back into place. We got to check the distal pulse at the fingers, tips, and at the radial pulse to make sure that they have good blood flow. But we need to have our team doctor or orthopedic doctor or the kids doctor evaluate that, give us a diagnosis, and they should not play until we have the approval from a physician before we start letting them back in the game. Rotator cuff strains. Again, strain is a tear to the muscle. Primarily the supraspinatus muscle is the most commonly injured rotator cuff muscle. So as I was talking about how the rotator cuff muscles slow the arm down, that's typically when they tear their rotator cuff muscles, because there's so much force to slow the arm down, especially when you're throwing a ball really, really fast and hard. That's generating a lot of force, and those rotator cuff muscles are small. So that is when the muscles typically tear. When an athlete who has rotator cuff strains usually have a long history of shoulder instability, the rotator cuff isn't strong enough to hold that humeral head in the glenoid cavity anymore, and so eventually it stretches out the cavity and it tears the rotator cuff. And so we typically, when we have a rotator cuff strain, the person is also having a lot of small dislocations. So our signs and symptoms here is the pain, swelling, point tenderness, loss of strength, especially if we know what the range of motions are and the actions that the rotator cuff are. We can test those things. The other one is they're going to have positive stability test that I talk about in the lab. So that's EpiCan test, positive EpiCan test, or Sentinella's test. And there's another special test for the rotator cuff, though typically we'll have a positive that test. Price in a lot of rotator cuff muscle exercises. We got to get that strength back. Again, this is something that an orthopedic doctor really needs to be involved with to see what kind of rehab that they want that athlete to do. Biceps tendonitis, as you can see in that picture, the bicep muscle attaches on the on the scapula, and the one part of the bicep tendon goes between the bicipital groove and the humerus. This muscle is responsible for shoulder flexion and elbow flexion, and this is an inflammation of the biceps tendon. It's common with athletes that do overhead actions all the time, throwers, swimmers, those type of things. So the MOI is just overuse. And here we have tenderness at the anterior upper arm. In this picture, it would be right in what's called the bicipital groove, which if you have your arm in anatomical position in front of you, which means your palm is out, and you rotate inward and outward, internal rotation, and you feel the top of your arm, you can feel the bicipital groove, and you can feel the tendon in your arm. That's where that pain is going to be out. You may get crepitus, which is a crunchy feeling, and definitely will have pain with activity. Our treatment for this is rest. I've had athletes that all they can do is play games. They couldn't practice because they had such bad tendonitis. Anti-inflammatory medications. This is a place where you might want to see if the doctor would do a cortisone shot, a cross-fictional massage again, heat before, ice after. There's some more advanced things that we can do for this particular person, but for this class, this is what we would recommend. All right, that's all our injuries. Let's review. We talked about shoulder anatomy. We talked about the bones. Talked about the 4 joints, the rotator cuff muscles. Injuries, we didn't talk about a lot of injuries. Talk about some dislocations and sprains, some strains, and bicipital tendonitis. Be careful of what you eat. And if you have questions, please post them in the Q&A forum, and I'd be happy to answer them for you.